So we're going to move on to clinical trial registries now, and our next speaker is Associate Professor Sue Evans, and she is the head of the clinical registry unit and Associate Director of the Centre of Research Excellence in Patient Safety. She's the registry custodian for the Australian Prostate Cancer Clinical Registry, and she is obviously very well positioned to give us some lessons from the Prostate Cancer Outcomes Registry.
Thank you. Thanks very much. And thank you to John and Rhiannon and ACTA Organising Committee for inviting me to speak this afternoon. I'm going to present how registries can drive better translation of real-world data into better quality care and taking the lessons from the Prostate Cancer Registry. So I'm going to briefly talk about the difference between a clinical trial and a registry. It may well be self-evident, but I think it's worth just highlighting on one slide. And then I'm going to talk about how our Prostate Cancer Registry and the Victorian arm of it particularly has driven translation into better quality care. So this is the usual situation as I see it for the differences between clinical trials and registries. Clinical trials largely inform clinical registries. Clinical trials are investigational, they're putting into place something, whereas registries are observing whether that which has come out of a clinical trial perhaps is actually happening in the real world. Clinical trials measure the efficacy of a treatment in a very carefully selected cohort, whereas a registry is looking at translation and whether that effectiveness occurs across a population. Oftentimes, registries are much better funded than clinical trials are. They are resourced, whereas registries often run off a shoestring. Clinical trials have a finite period for which they're recruiting patients, and registries are generally ongoing. Clinical trials collect a large amount of data fields. Registries pride themselves on the fact that they collect very few data fields. Clinical trials in the hierarchy are seen as providing level 2 evidence, whereas clinical registries as cohort studies are considered level 3 evidence. Clinical trials are very good at providing gold standard in determining comparative effectiveness of different products, whereas I think clinical registries are able to provide a pragmatic view on comparative effectiveness of different interventions. So clinical registries, or particularly clinical quality registries, are established with the primary purpose of monitoring and benchmarking patient outcomes, and their goal is to reduce the evidence practice gap. Evidence practice gap is really the difference between what should happen and what does happen in practice. Put scientifically by Sackett, it's conscientious, explicit and judicious use of current best evidence in making decisions about the care of individual patients. So in terms of that evidence practice gap, it's been determined by Grohl quite some time ago now, but it's still, I think, very relevant today, is that there's a big gap between what should happen and what does happen. It's been shown in clinical practice that up to 40% of patients fail to receive treatments shown to be effective, and that 20 to 25% of patients receive treatments that are not needed or are potentially harmful. In cancer, late last year, there was a study looking at the evidence practice gap. They found that there were 160 publications examining this. Most of the studies examining the evidence practice gap have been undertaken in breast cancer, very few in prostate. What's interesting when you look at the evidence practice gap, a lot of studies will describe it, but there are very few studies that have been undertaken to actually intervene and reduce that evidence practice gap. And that was the goal of the Prostate Cancer Registry, was to take what is known to be best practice and to investigate whether it's occurring and to intervene to make sure, or to at least hope to promote, that evidence practice care is occurring. The registry was set up in 2009 as a pilot in 6 sites across Victoria, group of clinicians got together, lamented the fact that they really didn't know what was happening to patients between diagnosis and death. There was some evidence from the Cancer Registry that there was a huge amount of variation in survival between different areas of Victoria, but we really didn't understand why. And they were very keen to understand whether patients were receiving good care and whether the care had anything to do with the difference in survival. So they set out to benchmark and report treatment and outcomes, providing risk-adjusted reports back to hospitals and, importantly, back to clinicians. And the aim of the registry at its very inception was to reduce that evidence practice gap. This is how registries work. We first have to identify what good care looks like, and we've heard before that a lot of the guidelines are based on level 2, level 3 evidence. So we have to sort of work out amongst the clinicians and with the clinicians what good care looks like and how it can be measured. Then to collect that data is the next very important step, making sure that you're collecting entire population-based data and providing it back to clinicians in a format that they understand on an ongoing basis. I think there's good evidence that audit and feedback is really only effective if it's being given by a credible person and it's ongoing, it's not seen as a time-limited exercise. So we were committed to the long haul, and the first thing that we did as a group for the Prostate Cancer Registry was really try and define what good quality care looks like based on evidence-based guidelines. And this was the group of indicators that we initially selected. Well, one has been added subsequently because of the more recent release of the optimal care pathways, but we wanted to measure whether treatment was timely, appropriate, effectiveness, safe and patient-centred. You might recognise that these are the dimensions of quality. These are the indicators that we selected. And we started the journey of collecting data. Unfortunately, I would agree with so many today that have lamented the fact that our IT systems are not set up for good data collection. A lot of our data collectors work in consulting rooms, private consulting rooms, taking data off software systems manually, and it's time consuming. But we're very committed to collecting really high quality data and providing these quality of care reports back to clinicians and to hospitals, which we've been doing every 6 months for the last number of years. Earlier this year, we published some of our findings from this work that we've been doing, and we were very keen to be involved in the Australian Commission economic evaluation of the registry because we really wanted to know the economic benefit or cost, and I'm pleased to see the reports coming out soon. But the early indicators that we published in the MJA earlier this year were accompanied by an editorial by Paul Croft, an oncologist, who mentioned that measuring quality of cancer care services enables systematic improvement by health services and clinicians, and quality indicators measured across the health system enable facilities to benchmark their performance against that of their peers and assess change over time. We have seen improvement over time. I've just taken some of our process of care indicators to describe here today. They were the ones that we selected from the larger list of quality indicators to present. We've seen an improvement in the number of high-risk men who receive treatment within the first 12 months after diagnosis. We've seen a 50% reduction in positive surgical margins after adjusting for the stage of disease, and that's been really, really wonderful to see. And importantly, we've seen a 4-fold reduction in men with low-risk disease undergoing surgery. This has come out in 2012, but prior to that, even in 2003, there were some studies, clinical trials, investigating the impact of early surgery compared to active surveillance on survival, and there's good evidence that men with low or very low risk disease should be put on an active surveillance program rather than having surgery, which carries a lot of consequences in terms of poorer quality of life. And I'm really pleased to say that our results in Victoria now show that men with low and very low risk disease are having surgery at a rate of 8%. That really is leading the world. Last month, a publication in the JAMA Oncology by Stacey Loeb looked at active surveillance occurring in Sweden using their clinical registries, and she reported that there was a 20% rate of active surveillance amongst men with very low and low risk disease. And in the conclusions within the abstract, they say that these data should serve as a benchmark to compare the use of active surveillance for favourable risk disease around the world. And I'm really pleased that we can, say that, well, in Victoria, we know our active surveillance rate is down to 8%. How much of that's been due to the registry is difficult to quantify. The economic evaluation that comes out next week in the Australian Commission has looked at early adopters versus late adopters, and so we can with some confidence say that the registry, we feel, has played a pretty active role. We actually send back to the clinicians the names of the patients who have had surgery but were regarded as being in the low risk group. And I think that's really important. I think that demonstrates that we have enough faith in our data that we'll stand behind it. The reports have gone back to hospitals for some time now. We've seen health services take notice. They review, they go back to the head of unit and to the quality department. And in some hospitals, we've seen practice actually stop. We've seen surgery stop because of outliers. We've seen change in surgical training programs that have now been implemented nationally by the Urological Society. And that's really, something that prior to the establishment of the registry, these hospitals would never have actually known that they were performing at a rate or at a standard that was perhaps not comparable with their peers. We've been able to look at variation in some of the geographic regions across Victoria, looking at why it is that men in particular areas are not surviving as well as in other areas. We've identified that men in some areas present with later stage disease. They're more likely to present with symptomatic disease. They're more likely to have delayed treatment, and they're much more likely to have poorer quality of life afterwards. So this is the descriptive part of the registry's function. The important part is making sure that that descriptive information gets back to where it needs to go and that health services are doing something with it. And that's somewhat frustrating as a registrar custodian to let go of that data and not necessarily understand what happens within the health services. But we certainly present back to the Integrated Cancer Services and to the hospital CEOs. And we're very pleased that there has been action within hospitals to change practice, an investment of funds to improve services, and also increasingly better services to look at survivorship issues of men with poor quality of life. It's all part of this quality improvement cycle that we hope and we feel reasonably confident the registry has been able to facilitate. So the question I was posed was, how can registries drive better translation of data into better quality care? I think it's important that it's population-based, that there's no cherry picking, that we have all patients in the registry, that it's clinician-led, that it's highly regarded because it's got good quality data, that we do the benchmarking, we send it back. It's seen as an ongoing quality improvement exercise. We're in it for the long haul, and that we really very actively engage the clinical community. Look out for this report that's coming out. My steering committee, very grateful for Jeremy as lead to that. And the funders. We're now actually a global registry, so it's a very exciting time for us. Thank you.
So we did start late, so I think we're all right to finish late. So we've got time just for one question, if there is one.
Peter Beck-Isaac. I understand that with registries, the issue of opt-in, opt-out, active consent is something that tends to be that you have to actually consent people to be part of registries. Is that not true?
No, we use an opt-out consent model in all our registries, and it's pretty universal across them that we have a less than 3% opt-off rate, so we are really collecting population-based data, and that's so important. If we were to rely on an opt-in model, then we'd be lucky to get 30%.
Okay, and secondarily, is there anything you can, coming from a general practice background, knowing when to do that PSA, how to diagnose the condition, is there anything the registry can tell general practice about how to better manage the issue of screening and early presentation?
Yeah, I think as an advocate, I mean, we certainly had a prostate cancer summit here a couple of months ago, and general practice was amongst the group there, and giving them evidence, I think, on the implication. We're now seeing that conflicting guidelines in the Red Book saying that not to screen is having impact on, in the most recent cancer registry data, you'll see this year that for the first time in many years, the incidence of prostate cancer is actually increasing. So we do need to be better, I think, at engaging general practice. Providing back this data, I think, is really important, and it's probably a missed opportunity at the moment. We've really got to bridge that gap. But yeah, information, I think, is the answer here.